So, in terms of our relationships to the patient, we'll look at a number of things that are important to that. But the primary thing that we're doing is we're assessing the patient, we're assessing them cognitively, we're assessing their history and their background, we're assessing the order. Is this the right order for the right exam? Are there other exams that maybe they should be considering? We may be educating the patient in that process. We may even be educating the ordering physician. So there's a lot of different communication channels that we need to think about. And then we're also going to be preparing the patient for the exam too. Okay. So, in terms of getting a clinical history from them, a lot of times we'll be using some kind of form to acquire that, right? And so I've got copies of the Baptist form, and we'll pass those out. That's kind of the learning exercise for today, is just looking at how the form looks. What are things that are on the form? What are things that are off the form? Just how best to use this form. Is there things that we might do better? But the big thing is symptoms, trauma, and duration. How long has this kind of thing been going on? And then in terms of medical history, I'm interested in previous procedures or surgeries. A lot of times patients forget when a surgery was. I found that in my own case too. Like, I've had surgeries, I can't recall exactly what the date was for those surgeries. I think largely because we want to forget having had surgery, right? No one wants to sit around and think about their surgeries. LMP or pregnancy is pretty much required for any woman in childbearing age. That's corporate policy. If for some reason it's not ordered, we will be taking that patient back or waiting for an LMP or pregnancy test, of HCG, whatever way they're going to get that pregnancy test. If a woman can accurately report when their last menstrual period was, there is, I believe it's 10 days after onset of menses is the best possible time to get a CT scan. Because it's the egg at that point is, the ovum at that point is pre-implantation. It is not yet attached to the wall of the uterus, or the wall, of the fallopian tube. I don't understand. I apologize for my profound ignorance of how these things. It is not, if it has been fertilized, it is pre-implantation, and it is not capable of conception at that point. Does that make sense? After that, we have this 2-week window where major organogenesis is occurring, right? So if someone was pregnant, they might not know it at that point because they have not yet started mensing, or they have not thought, hey, I just missed my mens, right? Is that how you say it? I don't know. I'm not a girl. I missed my period, I guess. And
I don't think that's a normal.
no, that's not. Yeah, it's not like you're sitting around thinking this. Oh my God. It's like times like this. It's like I wonder if male menopause is for real. My wife calls it hormotional. They're not yet. That patient realizes they've not yet had the opportunity to be hormotional, and therefore I know it's terrible. I'm failing to relate to y'all on any level right now. Just crashing and burning.
Just keep digging it.
Just digging it deeper and deeper. I'm glad this is going to be on YouTube. The significant point here, right, is that there are 2 weeks right there that are kind of like a buffer zone. So if I know, okay, this person is trying to get pregnant, right? They tell me as I'm talking to them, like, are you trying to conceive right now? Are you trying to get pregnant? I am interested in that because, not because I'm some kind of creep, but because if they have conceived, they are before the point when they might think, hey, I need to get tested and see if I'm pregnant, but they're at a critical juncture for that for that unborn life, right? Where major organogenesis is occurring, right? And the levels of radiation that we're dealing with in CT are significant enough to be of concern. All right? In addition to that, the contrast that we use can present problems for if they have recently delivered and they're lactating, they're breastfeeding their child. There are questions about the contrast is going to be greatly diluted by the biological processes going on there, but there would be trace amounts of iodine that would remain in the breast milk. It is not considered clinically significant amounts, right? But the mother should know that, and in the past we instructed lactating moms to pump and dump for 24 hours. Any questions about that whole bugaboo? It's got really warm in here. All right. Diabetes is important. In the past, we were very concerned about metformin and things like that. Not so much anymore. We'll look at some changes that have happened, but a lot of the metformin questions are still on the contrast questionnaires. But the most question?
No, it's just like I'm at outpatient in DeSoto, and if they're on metformin then, or any type of metformin for diabetes, and they haven't stopped taking it for 2 days.
Right. This is a common thing. What happens is the doctors get together, and sometimes the physicists get together, and they make all these decisions together, and they leave technologists out of the conversation. So the ACR releases all of their recommendations and stuff, and after 2 or 3 years, it finally reaches the technologists who are actually performing the exam. Oh, by the way, you don't need to ask about metformin. So it's one of those better be safe than sorry kind of things until it comes down from corporate policy to continue to ask those questions.
They told us that it was because as long as it's on that paper, it's Baptist policy to ask.
Right. That's a good way to think about it. As long as it's on the paper, it's Baptist policy to ask. We'll look for policy to guide our decision-making at the clinical level. But just know that there's a lot of things change with contrast. And so if you're working in a CT department, every time the ACR releases a new kind of contrast manual, that's kind of a big event. I've given you, I think I included it in the last email. Look at it. It's a big document. If you think you're supposed to read that whole thing and understand it, you're not. You're supposed to be able to go through it and find the parts that are important, that are relevant to you. So one of the things that they're questioning now, they don't think that metformin's a problem. What they do think is that any amount of contrast probably causes some form of kidney damage. Any amount of contrast may cause some form of kidney damage. Okay? So I would continue to ask the metformin question. Allergies are important because if a person has a big long list of, like a laundry list of allergies, like they're the boy in the bubble, chances are they're going to have some kind of reaction to contrast. Interestingly enough, a contrast reaction is not technically an allergic reaction. We call it a contrast reaction for a reason. Allergic reactions, if you have an allergic reaction to something, it'll be pretty bad, right? You'll get a rash or hives or whatever. The next time you're exposed to that thing, it will be worse, right? It will be worse. And that's the definition of an allergy. That's the working definition of an allergy. That repeat exposures increase the severity of the response. Contrast is not like that. Contrast goes up and down. And there's clearly a lot of factors for why contrast does that. But we call it a contrast reaction because it is allergy-like. It will look like an allergy attack. They'll have hives. They might have shortness of breath. They might have difficulty breathing or feel like their throat is kept closing off. So it will seem like an allergic reaction. It is not technically an allergic reaction because they could have a repeat exposure to it and have no problems whatsoever, right? But we continue to ask questions about allergies and stuff. And another myth around contrast, and our book even points this out, is there's no correlation between shellfish and contrast reactions. None. But a lot of forms continue to ask, are you allergic to shellfish? that's been completely discredited, but it continues to be there. Another example of there's fraudulent things that occur in medicine. I don't want to beat this drum too hard, but who here remembers about the question about whether inoculating your child was linked to autism? Does anyone remember that? That was a big deal, right, when it came out. That was totally fraudulent. That was like huge quackery. There was a doctor who actually had an invested interest in a different vaccine who published something in Lancet, the British Journal of Surgery, about a link between the, I guess it was like a mercury or something like a fixer that was in the vaccine, and that it was directly linked to autism, and it caused a huge public scare. And there's people who continue to believe that, including celebrities who are kind of endorsing don't inoculate your child, right? Inoculate your child, please, because the way that we keep people from having things like smallpox and stuff is by having a community resilience, right? But that's just one example of how people can be fraudulent in the way that they report things. Screening. As I'm screening the patient, I'm going to be simultaneously educating the patient. And I think that's what keeps this thing a dialogue. As I'm talking to the patient, I'm asking all these questions. Don't just be a robot, please. Like, I was talking to a radiologist the other day, and he was kind of bemoaning the fact that someday they're going to be able to replace an ER physician with a robot, right? Or a patient will be able to admit themselves to the ER. They'll just click off something on the internet that says, do you have shortness of breath? Yes. How long has it been going on? For 2 days, And just admit themselves to the ER and just bypass the whole physician screening process. That's kind of, honestly, I think where insurance companies would like it to go, because it probably is more efficient or whatever. But as you're going through this form with the person, keep it conversational and try to engage them and use it as an opportunity to educate them both on the process of getting a CT scan, that you're a technologist, you're not a doctor, you're not a nurse, you're here to perform the exam on them. The exam involves this, that, and the other. Breathing instructions are really important. It's helpful for them, especially if you're going to be using contrast, to go ahead and empty the bladder before they head in there. Things like that. Y'all ask them to clear their bladders too in Nuke Med, right? Yeah. Okay. And y'all have them void right before they go in for a PET too.
Yes.
Okay. All right. LOCM, low osmolality contrast media. So that's the fancy way of talking about LOCM. Just means low osmolality contrast media. And so we'll ask them questions about certain contraindications to it. Okay. Again, this is an opportunity to educate them about the contrast media. Now, I've had every spectrum of person who wants to know different levels. Some people don't want to know anything about what I'm doing. They're just like, just do it and get it over with. I don't want to know anything about it. Other people, I've had 1 or 2 patients ask me for the chemical formula for what is in non-iodinated contrast media. And I will tell them it is organically bound iodine. It is iodine off the periodic table that they've bound to some kind of carbon molecule to make it mimic like an organic compound. I can show you the formula. It's there in the box. Like when you open a box of contrast media, there's a little tear-out pamphlet that tells you all sorts of stuff about what's in it. It'll have the actual formula for how contrast media appears. But the main thing that I tell them is, like, number one, we want to make sure your kidneys are functioning well. That means before and after this exam, I want you drinking lots of water. Not beer, not wine, water. Not coffee, water. Not Coca-Cola, please. Water. Water, water, water. Drink lots of water. That's probably the number one thing that you can tell them. Because, again, what the research is telling us is that the number one problem, again, with contrast media is probably some kind of kidney damage. The number one way to avoid the kidney damage is water. Water's also going to help with the barium, too. I tell them the barium comes in white, it's going to go out white. Don't be alarmed by that. Right? When I give you the contrast, you're going to feel warm and flush. You might feel like you wet your pants. Some people say they taste something. I had one lady describe it tasting like tequila. I've had another person say it felt like they had a penny in their mouth. Have y'all heard any of those descriptions of contrast? We're going to be pushing it pretty fast, right? So I'll let them know that I'm going to start an IV. I'm going to be testing that IV quite a bit. I want you to let me know if at any point the IV starts to become incredibly painful. right? They need to know that. And then, of course, the important thing is just for them to hold still. I've had some folks, she gives a range of 0.2% to 7%, so very, very, very small number of people. Like half of a person in every 100 people, one person for every 200 scans that you do, right, is going to puke all over the place. This is not a contrast reaction. It is just someone puking all over the place. And it's disgusting, and a lot of times it is like something out of a movie, like crazy amounts of puke. I hate to say that, but that's what happens. So keep emesis basins close at hand. In general, those people are having an anxiety attack, right? And the way that their anxiety triggered was on that digestive tract, right? It clenched up their stomach and projectile vomited everywhere. I had one guy that I CT'd quite a bit. Have I told you all this story? I had this guy, he had, I think, non-Hodgkin's, so he had a lymphoma. This young guy, he was on a cancer trial, and so we kept on doing CT scans like every 3 months or something. And really skinny, kind of emaciated guy. Every time I put him in the CT scanner and started a contrast injection, vomit everywhere, right? It got to where I was seeing him enough that I just knew, do the injection, let him puke, then do the scan. Don't try to get the scan while he's puking, right? If someone's puking, stop the scan and reinitiate it after they're done puking, right? Because if they're puking, especially if you're scanning their abdomen and pelvis, they're going to be heaving, and there's going to be all sorts of motion on that scan. The pictures will be non-diagnostic, right? I know that it's going to screw up your timing for the contrast, but just note patient puked all over the scanner. And the doctors will know that that's that 0.2 to 0.7%. It's probably an anxiety attack. I've also seen people who are having something like an anxiety attack, and it looks a lot like a contrast reaction. They start having shortness of breath, acting kind of crazy, and it is very hard to differentiate between that and a contrast reaction. I would go ahead and treat that as a contrast reaction. I would go ahead and call a code and treat that as a contrast reaction. Consent. Prior to start, they need informed consent. That's why I've been building up and telling them about the exam. They need to know the risks of the exams. We're using radiation, and we're using something that you need to hydrate your kidneys because it could hurt your kidneys if you let it sit around. And if they ask me about how much could it damage my kidneys, I'll say about as much as a Coca-Cola. Do you drink Coca-Cola? It damages your kidneys. Probably causes pancreatic cancer too.
One of my friends posted on Facebook, she's older, and she used to drink 12 to 16 Pepsis a day, and her doctor told her that she was going to have liver failure and her pancreas was going out, so she quit cold turkey. It's random fact yesterday, so I had to...
Yeah, no, did she have headaches when she went cold turkey? Or she's going cold turkey now, and she's at home going like this. No, my wife, when she was in undergrad, she drank 6 Dr. Peppers a day to stay up, and got all sorts of crazy UTIs and stuff. So yeah, try to avoid it. I'm sorry. Someday you're gonna meet my wife and you're gonna be like, "You're the girl who had all those UTIs from the Dr. Pepper." It's this is not my permission to tell other people. Just forget I said that. And it's also on YouTube now. HIPAA violation. She's quit, drinking the Dr. Pepper. No more problems, right? But contrast I think one of the best things you can compare contrast to is Coca-Cola. Patients will ask you, well, what exactly is this stuff? It is sticky like Coca-Cola is sticky. You will see it if it's been dripped on the floor, or if it's gotten on the scanner or anything like that. It's very sticky. The easiest thing to remove it with is just warm water. Just pour warm water all over it, and it will kind of dissolve into the warm water. No amount of scrubbing or chiseling or anything is going to remove this stuff. Really, really, really try to avoid it getting inside of the CT scanner gantry because it can actually distort the images. So I'm going to be informing of those risks, the risks associated with radiation, and as well as the benefits. The benefits are we can know if you're having acute appendicitis, right? We know with a tremendous amount of specificity whether or not you've got cancer, and we can grade it, and stage it, and all of that. And that's the way I constantly give it back to the patient. Do you want to know what's going on today? Okay, well, this is what we need to do. Alternatives. Are there alternatives to this exam? ideally their doctor should be giving them this information, but a lot of times no one's discussed alternatives with them. So I'll say, have people discussed the alternatives with you? The obvious alternative, especially for young females, is ultrasound. And then it's required, a signature is required. Implied consent is if you've got someone who's gorked out from an MVA and they come into the CT room and they got IVs and nurses all over them, I'm assuming that they would want a CT scan, right? Y'all know what gorked out means, right? Like non-responsive. Yeah, you see some of those folks. Okay. Communication. How to. You're going to lie on your back, move in and out of this giant plastic donut. Keep it simple, please. You know? It shows confidence in what you're doing, and it helps them better understand. Understand that the person that you're talking to is probably very anxious. And they may not understand everything that I'm saying if I go into some highly technical explanation of all the stuff that's going on. Let them know that timing is critical, and you're going to do your best to get it done in about 20 minutes. I can get a CT scan done in about 5 minutes, but I figure if I tell them 20, then they'll think I'm amazing because I got it done in 15 minutes short, right? The contrast type and the route, I'm going to tell them, I need to give you both. You're going to have barium to drink, so it's going to taste kind of chalky. I'm also going to start an IV, and we'll do an injection of IV right before scanning. Okay? I need you to hold still. If you move too much, it's going to cause motion, and it'll actually distort the images. We won't get pretty pictures. We all want pretty pictures. Remove any metal. Metal causes like a streak artifact. There's always going to be the person who says, well, I've got some kind of weird piercing or something. Go ahead and leave the weird piercing, and it's fine. Right? I'm not going to make you remove your weird piercing. I shouldn't say weird. They have a piercing. And then follow-up. That's always like the first question that people ask when you're done with the exam. What did you see? When will I know the results? Go ahead and preempt it. I found if you go ahead and tell them before they even ask, they tend not to ask any more questions about it. So I'll just tell them, look, you're an ER patient. We'll know the results in 30 minutes. If you haven't heard results in 30 minutes, hit the call light and ask your nurse what's the results from the CT scan. Oh, yeah, I do. As much as I've had to deal with crazy nurses in the ER, that's one of my favorite things to ship back to them. Here's an informed patient for you who knows what our turnaround time is for CT results. Right? You've called me 12 times to do your stupid exam while the patient was waiting for their 2-hour prep time, and you knew that. Here's a patient who knows how long it takes us to get a report. So yeah, that's a little present you can give your ER nurses if they're on your nerves. But again, if you want to upsell the ER, you'll have a report in at least an hour, right? I love your ER nurse. She's amazing. He's amazing. That's your choice. How are you feeling that day? But yeah, some kind of follow-up. If you tell them a follow-up question, also I think in terms of telling them a follow-up, well, why does it take so long? Why does it take 2 days? I hate that it takes 2 days on an outpatient imaging. Sir, today we acquired over 1,000 images of your body. The doctor wants to go through those as thoroughly as possible and compare them to any prior exams. So that takes some time. Just preempt it. Okay, immobilization. So the ART calls this immobilization. I do not use the word immobilization or the word restraint. I say support, and I think that comes from working in radiation therapy for 5 years. Now, granted, support may involve me with you in a headlock, and I'm supporting you through your CT scan, right? I'm willing to support you in that way. But I do not immobilize anyone. If a person is immobilized at the time that I show up in the room, I will keep that immobilization in place as best as possible. If they are incarcerated and they're coming from the jail or something and they have handcuffs, you're going to need to make sure that all those kinds of things are out of the area that you're scanning, of course, because they're metal. Things that we generally use in the CT department are straps, bean bags, sponges, and lead aprons. These a lot of times are just reminders to the patient that you're sitting pretty high up. If you support the person's knees, of course, their lower back's going to be more comfortable. The scan table's kind of weird to lay on. And then lead aprons can actually be used to kind of help remind the patient, hey, I need you to hold still. If I'm doing a CT of your head, there's no reason why I shouldn't lay a lead apron on the table and lay a lead apron over the patient when they lay down. You're going to have to use 2 lead aprons, right? One for the table and one for the patient because you're spinning around them while you're taking x-rays. There's no reason to put shielding on just one side. And I think a lot of the Baptist facilities, they use something that's like less attenuation value than lead over the patient's eyes or breasts, right, for female patients. Those are good things too. They also, again, just serve as reminders. The minute you say to your patient, okay, that's it, they're going to jump off the table and bang their head against the gantry and fall on the ground, and they're going to have a class action lawsuit against you, right? So when you come back into the room, the best thing to do is not say anything, you know? They assume that the exam's still going on. Lower the table down, remove the IV, and then say that's it. My tendency is, like, as soon as I'm done, like, whoa, that's it, I can get this person out of here, right? Unless they're gorked out, just keep it to yourself. Be silently satisfied. All immobilization, if they come with immobilization, they're required to have some mobility. They need to be padded devices. It needs to be in normal anatomic position, so no crazy stuff like this, you know. Knots that tighten with movement, right? Shouldn't be impairing circulation or respiration. And if you've got a person on the CT table and you're using wrist immobilization, you have to have leg immobilizations as well, right? So if they jump off there, it will be interesting. One of the things that has permanently etched into my mind is when I was, again, about, 15 or 16, I was biking around with my brother in this parking lot. I found a dog that had hung itself, right, out of this guy's truck. He had it leashed up in the back of his truck. It jumped out of the truck and hung itself. It was terrible. But the same kind of thing can very easily happen with immobilization devices. Monitoring. So monitoring is not something that begins once we have them in the CT department. I'm going to begin looking at what their level of consciousness is, what their vital signs are, what their heart rate is, oximetry, as soon as I get them from the ER or wherever. If they're a walkie-talkie patient and I'm bringing them back, I think it is wise, and I know a lot of places they might not practice this, it is worthwhile to go ahead and get a blood pressure before you do a CT scan with contrast. Because that way you have a baseline blood pressure before I give them any contrast. So if they do have a reaction, when I call the code, I can say before I gave them the contrast, this was their blood pressure. Has it falling off? Yes, they're going into shock. Right? So baseline blood pressure is pretty easy. We've got robots that can do it. So once I've got the patient on the table, I've got the IV in one arm, I can put the blood pressure cuff on the other arm and get a quick blood pressure while I'm doing my initial scout scans. Right? The other thing that's going to be very helpful, I think I shared with y'all what happens if we bring the patient's arm up, it can kink a vein. If that kind of process is going on the blood pressure arm, it's going to make me that much more aware that it could be going on this side. Right? Something to think about. Heart rhythm, oximetry. I love the ER patients because you can just grab the box and go. Right?
So you're saying don't bring the arms up?
Do bring the arms up, right? But be very aware that if you've got an antecubital IV in a patient and you're going to power inject on them, right? Do you know about how much your PSI is in your car tires? Any guesses?
32.
About 30, 35, right? PSIs for power injectors is like 200, right? So when you think about it, if you push down on a car tire, how quickly that air is coming out, now you're injecting power injector at 200 PSI. The problem is this, right? We can have extravasation that happens outside of the area of injection. So for example, I had a sweet little old lady, had a good IV, doing a CT of her chest, initiated the power injection, and the injector never hit any of its PSI limits. It injected everything perfectly. Scans initiated. There's no contrast. Where's the contrast? It was up in her shoulder. She'd brought her arm up, right? It kinked off the vein, and it blew up here in her shoulder, so now she's at a risk of probably having permanent damage to her shoulder. So learn from my mistakes. Know that when you bring someone's arm up, right, it is worth going ahead and testing the injection again. You'll see techs, they always grab a syringe of saline and push it as fast as they can. It's okay to do that immediately after starting the IV. I would encourage you to go ahead and do it again after you bring the arms up, especially if you're doing any kind of power injection for like a CTA or something like that. If it's a routine CT scan at 2 milliliters per second or whatever, you're probably okay. But if you're pushing faster than that, bring their arms up and check that IV again. That's a really good question. Am I talking too fast about that? Did all that make sense? Okay. Level of consciousness. If they've had a seizure, a stroke, shock, or any kind of alcohol exposure, or if we see a Glasgow coma scale, right? We need to be kind of just familiarize ourselves with what those different things are. So just to go back, the one slide, I'm sorry, I can't really move back. But for monitoring about what's the normal respiration rate for a patient, yeah, 12 to 20 for an adult. Let me see what else have I got here. So for vital signs, blood pressure and stuff like that, what's about a normal blood pressure for an adult? 120 over 80. And then same kind of thing. I may ask a patient, have you had a seizure recently? Did you currently have a seizure? If I'm doing a CT of their head, have you ever had a stroke? Do they appear to be in shock? Things like that. Again, having a blood pressure can be a good determiner of that. If the patient is drunk or in some way mentally impaired, whether it's pathology like Alzheimer's dementia or a mental disability or something like that, I am going to need to tailor my CT scan a little bit to their specific needs, right? If I have a patient, for example, who has Down syndrome, I need to understand they're probably very afraid of everything that's going on. They probably have had a lot of terrible experiences in hospitals, right? So I need to do the best that I can to explain things as simply as possible. The way that I do that is this. When I'm meeting a pediatric patient or a patient who has any kind of cognitive questions, I'll tell them, here's the rules of what's going on. We're just getting pictures. To get good pictures for the doctor, we need to stick together, no hurts, and have fun. Right? Stick together, no hurts, have fun. If they're operating in a state of fear or arousal, they are not ready to listen to some really beautiful, articulate discussion of what a CT scan and the beauty of the pictures that it can give you, and etc. They need something very simple. So for my drunk friends, I'll confide with them that I used to be an alcoholic. I've been in AA. I know where they're coming from, right? And a lot of times by the time I'm done with them, they're going to be crying like a baby, right? Other folks will come in there and be like, get on the table, hold still, and the drunk's going to swing on them, right? Now, granted, there's different levels of ETOH, right? There's like the level, the one that you like is the one where they're crying and they're crying on your shoulder, right? If they get beyond that, there's like the violent part, then there's like the hilarious part where nothing they're saying is funny, but they think it's funny. So it can be very helpful. If you walk into a room and the drunk is violent, wait and come back 20 minutes, they'll probably be less violent, if you have that luxury. If they swing on you, just say, sir, it's my understanding you don't want the CT scan at this time. I'll come back in just a moment. Come back in just a moment. A lot of times they'll have cheered up. Okay? Sometimes you just don't have that option. I think that's it. So, body temperature should be around, what, 98? Oral, I think. Pulse is around 100 for someone like me, right? Respirations, we already said, should be about 12 to 20 per minute. And their blood pressure, ideally, is going to be around 120 over 80. Those are all significant. It's helpful to note those somewhere in the chart or on your requisition, because again, if you have to call a code, it's very helpful when the code team gets there and they start doing everything to have some baseline to work from, right? Okay. Let's talk a little bit about heart rhythms. So it's all controlled by this sinoatrial node, right? It's that little, I wish I had a heart, let me see. It's this little thing right up here. It initiates a series of chain electric shocks that cause the ventricles and atrium to contract, and that's what moves the blood through the heart. Atrial contractions happen on the P wave, and then ventricular contractions have this QRS complex where we see the little telltale boop boop, and then it goes back to a relaxation, and then it goes through and initiates another P wave. This is really, really important for us if we're doing any kind of CTA of the heart. And the reason it's on the board is because if I'm scanning a patient's heart, when's going to be the best time to get a picture of the heart knowing what I know about motion? During relaxation, because it's not doing anything. So a lot of scanners we're going to actually hook the patient up to some form of EKG, right, or ECG, whatever you want to call it. We're going to look at when the heart is beating, and scans are going to be initiated each time it's in that T wave, right? And so it's what we call gating, cardiac gating, okay? That's the reason we need to know this heart rhythm stuff.
So we saw some CTAs recently of the heart where they were doing gating, and they're looking for the P wave.
Are they? I could be wrong about that.
Because they said, I mean, like, well, we were watching.
The P wave might be what's turning it off. Like they might be telling the machine, stop it when you see the P wave, right? Reinitiate when you see that QRS. Does that make sense? Each scanner, that's a really good point, and I'm going to have to defer that to the maker of that scanner.
They were saying that's how they gate. It's like because they have to watch the heart for so long to make sure that the heart rhythm doesn't change up and down too much. And they said they start with the P, they watch the P wave, and then the machine just looks at that rhythm, and then just sets the gating set based off of whatever that was.
That makes sense.
It's kind of like doing abdomen MRI. They have it watches when they're not breathing, like when they're exhaling.
Yeah.
Before it scans. And
Can I erase this?
Yes.
Because this is a good point. So what we have is a continuous process, right? And in my understanding, we have this P wave, and then this QRS complex, right? And then this T wave again, right? And then it reinitiates that. And I'm not a cardiologist, okay? Understand that. I'm a CT tech. I may have totally botched this illustration. But depending on the scanner manufacturer, right? I'm going to tell it, here's where that was, here's where that was, right? Then the software is going to calibrate itself to scan based on that. It's going to make just some time measurements, right? So it's not really technically gating. It's not actually waiting for the heart to initiate before it starts the scan. Because if I was triggering the actual scan off of the heart, there would be no way to actually tell the computer to do all of that complicated stuff. So rather what I'm going to do is I'm going to initiate just a scanning, a timing protocol. And that timing protocol is based on some distance. Does that make sense? So I'm looking at this ECG, and I'm saying this is the distance here. I've had 5 or 6 heartbeats at that distance. Okay, that's where our time is at. Scanner, you take that and scan from that point, right? I say that versus, so that is really just, I've just really changed the way the timing of the scanner works, right?
Okay, kind of like in cath lab, when we go in and we do our gating, you know how we have to watch for 3 beats before we can even gate.
Yeah.
You can't even start it until you've watched to make sure there's 3 beats that are consecutive.
When you think about how x-rays are produced and all the complex kind of mechanical things that have to go on, as well as the computational stuff that's going on, there's no computers fast enough to actually purely gate. Like I can give it, here's a timing protocol, now run with it, right? Versus something like a radiation therapy machine that's doing respiratory gating. Then it actually is watching how the person's breathing and stopping the radiation treatment, right? And then waiting for that breathing to relax and then starting it again, right? So it is real time. I don't know. I'm not trying to belabor the point, but Chris brings up a really good point of discussion. So again, the point that I want to make though is again, it's going to be based on the modality, the manufacturer of that machine, where you tell it to time off of. But the main thing is that we're looking for it to be scanning during a relaxed phase of the heart's rate. Does that make sense? Okay. So here again, we see that this is just kind of graphed out, kind of nice and neat, where we see the different areas and how they're firing, when they're firing, and that QRS complex is kind of the thing that we're watching out for, right? That's going to be when there's the most motion in the heart. That's when we don't really want to be scanning. Oximetry. Honestly, in CT, one of the best people to become friends with is respiratory therapists, right? Because we deal with people who have some kind of lung problem quite a bit. So respiratory therapists can give you a lot more information than I can about what the different noises and the different vocalizations mean for how a person's respiratory health is, right? Normal O2 levels, though, are 95 to 100%. If they are having a contrast reaction, a lot of times one of the first things that we will hear is they will sneeze, right? So I am listening to breathing noises. Did they sneeze? Are they having a difficult time talking, right? So I will instruct a patient again. As I'm asking you questions, I need you to respond. I know that some of the questions are going to be redundant. I will probably ask you several times, how are you doing? I need you to say, I'm okay. Because I'm testing to see, can you still vocalize, right? Okay, let's talk a little bit about different kinds of medical devices. Of course, there's all the stuff for O2 delivery, like cannulas and bags and stuff like that, right? Chest tubes, we'll look at that. I've got some pictures of that. Who knows the number one rule with chest tubes if we've got a patient with a chest tube?
Don't knock over.
Don't knock over the chest tube, right? Keep the thing upright.
Don't trip over it.
Yeah,
Get over it.
don't do anything with it, basically. I talked to a student of mine who had a chest tube placed at one point in time. He was not in class with his chest tube, but he had one. And he said it was one of the weirdest, most painful things of his life when they placed the chest tube. He said you could actually smell it, right, going into you, and it's like someone stabbing you, and then you smell whatever they just stabbed you with, right? That sounds really heavy metal to me. So it's incredibly painful. Don't be like playing with it or anything like that. I know that y'all wouldn't, but any kind of drain, like a lot of times we see people who have abscesses and stuff like that. Be careful with the drains. Indwelling catheters. Ask the patient if they're from the floor, do you have a catheter in place? They don't need to be jumping around doing any dances. And vascular access. As a rule, right, you will learn whose IVs you can trust and whose you can't. And pretty much the people whose IVs you can't trust is everyone who's not you, right? If I start an IV, I know it's a good IV. I trust my IVs. If someone else started an IV, I'm going to do all sorts of weird tests on it. I might even remove the IV. I might say this IV is no good. I might send the patient back for vascular access. I may be calling someone who needs to start a better IV if I can't get an IV. I tell the patients I tried 2 times and that's it. I will call a nurse or someone. A lot of times the radiology nurses have those machines that can actually dig around and find an IV through some kind of ultrasound process, right? Do they have those at any of y'all's facilities? Okay. Get to be friends with that person. Are they friendly or not? Until you've really learned how to start an IV. Who here feels like they've had sufficient exposure to starting IVs?
We need more practice before going into CT and MRI.
See, we're not even sure if we're even supposed to be able to do any of that.
Okay.
Tell us at the setup.
The nuke med folks, y'all are all comfortable with IVs. You do IVs all day long.
As long long as they allow you.
Let's do this for one of our senior symposiums. Let's spend some time talking about IVs and working on IVs. Okay, I've really not found a good way to simulate IV placement. I used to be the IV instructor, or whatever. Like I would check people off on yes, this person can do an IV at the hospital, and a lot of times I would just let them do it on me.
Forever ago.
Yeah.
At Northwest, their nursing students have to stick each other.
Yeah.
So you know if, like if it hurts them or whatever, because I don't.
No, I'm a big fan of that kind of stuff. Like when I was in radiation therapy, we had to give each other tattoos so we knew what the tattoos were like. And the way I learned doing IVs was just the CT instructor that I had, it was more of a clinical based program. She was a very difficult stick. She said, if you can get an IV on me, you're good to go, right? And so when I was training people on how to do IVs, I would just say, okay, if you can't get an IV on me, God help you, because I'm pretty easy to get an IV on.
Whitney at DIS.
Yeah.
Little baby. She didn't even have a tourniquet on. She did her arm like this, and I was like, okay.
Yeah.
Right there.
Those people are the best people to learn on until they get all scarred up or something. But I'm going to talk to Deborah about what liability kind of things are here at the college, and we'll see if.
The techs at Collierville made me and him do it.
Good.
Before we could, but we do it.
Good. That's great. So Collierville sounds like it's a good opportunity.
Andrea's been sticking in CT at DIS
Good.
every time.
What about Memphis? Anyone at Memphis being allowed to do IVs? Being encouraged to do IVs? You know, I don't think so.
Do you have any want to?
Yeah. Okay.
They're allowed to do it, but
Yeah.
they have it doesn't happen often.
They have their own nurse.
Yeah,
Oh,
they
okay.
have a nurse that they're assigned to, and they just go to work with them. So if they happen to get a patient that needs an IV, then if they want to try it, they can. But it's not
I think getting an IV is one of the more satisfying parts of the job. You know, I mean, I don't know. I enjoy it. Okay, stuff to think about there. I'll try to figure out some way to get that in some symposium for us to talk about that more. Here's a chest tube. So we all know what these things look like. A lot of times they're gonna be hanging down the side of the bed.
They sit on the floor. They don't hang on the bed.
Yeah, I know. Well, if you're transporting a patient, right, it needs to be below the patient, upright if possible. Watch the thing. Yeah, they'll be sitting on the floor for you to kick over. A lot
At
of
4
times.
a.m. when the entire room's dark and you can't turn on a light,
Yes.
you try not to run it over the cordwall.
Yes. Yes. Yeah, no, these are all the joys of the job. Here's what a drain looks like. I love that this is called the D bag. Someone was really phoning it in there at the marketing department of Drains Incorporated. But it has some straps that typically go around the body, or it's hanging off the side of the body or whatever. This kind of drain doesn't have any kind of suction on it. It's just draining, right? You'll notice there's a little pigtail at the end of this thing, right? So after they placed this drain, they pulled on a rope inside there, coiled it up, and then they sutured that to the patient's skin, right? Don't mess with that. That would be incredibly painful, in my opinion, to have someone accidentally rip out sutures and then a pigtail thing as well, right? But if you're fortunate enough and you get on a CT rotation where there's some interventional stuff, I know that most of the interventional, I think at Memphis they do in a separate department. This is what they're doing a lot in CT is placing drains. Catheter, we all know what this friendly thing looks like. One thing about catheters, as a CT tech, it is helpful to clamp these things off, right? It is helpful in terms of, especially if the patient has had any kind of bladder cancer or if you suspect there being any kind of problems with the bladder, to go ahead and clamp this thing off, right? Typically, the way that I've learned to work with that is I always have one set of hemostats that's always hanging off of my scrubs right here. And if I'm working in a CT department, I'm constantly testing to make sure I got my hemostats on because I don't want them to wind up somewhere else, right? You can go to Army Surplus Store or wherever, buy a set of hemostats, or if you're working in interventional, just borrow some that are there.
enough away.
Yeah, I mean, you'll see like they'll do a prep kit and they are throwing stuff away. Grab the little scalpels and the hemostats and stuff if they're going to toss them and they haven't been used. Hemostats are really, really a good thing to have on you, and if that's the only way I would go about clamping these things off is to use your personal hemostat and not to actually clamp it with the hemostat, but to fold this rubberized tube right here over like this and use the open part of the hemostat to clamp it off. Do you understand what I'm talking about? Real quick. Don't use the little needly part of the hemostat. Oh my goodness. This is the female reproductive system. Clamp it off in here, right? In that little open spot.
But they have the little clamps already built onto them.
I know they do, but the problem with using those clamps is what?
You can't sometimes get them off.
True, what else?
They popularize it, they
Okay. Why would I just want to use my own hemostats on doing this? Knowing that.
Like the other one.
Yeah, well, I mean, there's contamination. I'm risking contamination because of something else. I want to make sure that if I clamp off a catheter, I remember to unclamp off the catheter, right? So the problem is if you're in any way forgetful like I am constantly looking for ways to remind myself in the hecticness of the workforce, like, oh my God, I forgot to take the hemostat off that thing. Let me run after them and grab it before they get up to the floor, and the nurse yells at me. So if I use the clamp on the catheters, let's just say there's been times where I've forgotten to unclamp it, right? So I learned to use the hemostats. If you're more mindful than I am, feel free to use the one that's on the catheter. Does that make sense? You want to make sure that you, especially, CYA, and you also, knowing what we know about contrast, and it's the fact that it's being excreted through the urinary system, I don't want to impede that flow any longer than I need to. But having an indwelling catheter will actually reduce the diagnosticity of doing the delay scans, like the kidneys and bladder delays. Questions about that? Okay. All right. Let's talk. Let's see what else I've got. Okay. All right. Here is an example of what. This is about 2 or 3 weeks out on an extravasation. So, in addition to these kind of gnarly skin effects, we can also have what's called compartment syndrome. So, a lot of times we choose vessels that are close to the elbow, right, or close to the wrist. If an extravasation occurs and it somehow infiltrates or compromises the synovial cavity around the joint, it could cause irreparable damage to that joint, right? Like pain and all sorts of stuff. So vascular access is very important. We'll talk about it a little bit more when we go over contrast. But just know that I want to make sure that my IV is good. It's not in any way compromised. That sometimes a little hep lock will come unscrewed and contrast is just pouring everywhere. You want to avoid that. But you also want to avoid any kind of extravasation. Lab values. So for our book, she talks about creatinine that is generally in the range of, I think she says normal is what? 0.6 to 1.7. 1.7 is way higher than anything that I've seen in terms of policy, but she says that's a normal value. I think Baptist policy is 1.3 and below. I could be wrong about that. But talk to the text and make sure that they're within that. Now, Baptist, again, this goes back to the ongoing debate about how best to gauge whether or not a person has good renal clearance. A lot of places are suggesting now we go to the GFR or eGFR, some way of calculating a glomerular filtration rate, right? That is probably going to be corporate policy going forward at some point. We can talk a little bit about that. Basically, you need the patient's age, their gender, their ethnicity, and their creatinine level in order to calculate a GFR. You can look up eGFR online, and it'll take you to the diabetes organization or someone. They have calculators right there. You could just plug those numbers in, and it'll spit out an eGFR.
What were the numbers?
Age, but
I think it's age, their gender, their ethnicity, and then their creatinine.
So weight doesn't have a factor?
I don't think so. An eGFR, if I remember right, the higher the better. Creatinine, the lower the better. But does that jive with what anyone else has seen? Okay, all right. It's been a little while since I've done an eGFR. I'm sorry should have familiarized myself a little bit with that.
You have a clearance form you have to fill out right
Yeah,
now.
that was gonna say, there's a clearance formula, like,
Yeah.
PET CT in Memphis, they have one, and you get their creatinine, and then you just put in the calculations and tells you what their clearance is.
Great. And what factors are you using to calculate it?
Their gender, age, creatinine.
Okay, gender, age, and creatinine is all you need for that. And then the higher the number, the better, because it shows it's saying the kidney health is this, right? Pretty high. Or the kidney health is low, pretty low. Okay, good. So it stands to reason that the lower the patient's age, the lower the person's creatinine, the higher their GFR will be, right? That's how the calculation works. We may also need to be familiar with some other lab values like coagulation, so I'll talk a little bit about different coag levels. And then also D-dimer and an LFT and HCG. Let me make sure I've got slides for all that. Yeah. So D-dimer, does anyone know why we look at D-dimers? What a D-dimer is an indicator of by any chance? Yeah. It's like a clotting predictor, right? So a lot of times they'll order a CTA of the chest to rule out pulmonary embolism for a person who has shortness of breath and elevated D-dimer, right? That's kind of becoming the standard of care. LFT, HCG, pregnancy tests, right? Okay. So here again are the numbers from the book. Be mindful that Badge's policy may be different. And BUN has pretty much gone away. I've never seen anyone refuse to CT scan based on a BUN value, but sometimes you'll see people come across or like a form asking for a BUN. Coags, there's prothrombin time. A lot of times they're just called PTs, PTTs, and platelets, right? So the normal prothrombin time is 11 to 14 seconds. The PTT is 25 to 35 seconds. And platelets somewhere in the range below 400,000, above 150,000. Elevated platelets indicate some kind of crazy infection. Falling off platelets means the person's having some real problems. So these are important, especially if we're doing any kind of IV or if we're doing any kind of procedure in CT like drain placement or anything like that. If we're not doing a drain or any kind of CT interventional procedure, we may not need to know these numbers, okay? It's just if they're coming in for interventional stuff. Okay. Anytime the patient is on Coumadin, heparin, Plavix, aspirin, we probably need to we need to recognize that in the electronic medical record, and it may ask us to do some kind of reconciliation work, right? A lot of times patients are asked to discontinue certain medications if it's going to cause problems. On the whole, though, they can continue to take their Coumadin. If a patient comes in for a CT scan, they're on Coumadin, I just need to be that much more careful with them in terms of starting IVs and things like that. Okay? With metformin, again, there's some debate about what exactly metformin does. I even saw some research recently that says that metformin may actually extend people's lives. So I would say there's quite a bit of debate, and there's still some gaps around metformin. A lot of CT questionnaires still ask about metformin. because it is controlling blood sugar by affecting the way the kidneys function. So, in general, the protocol is this. If the person is on metformin, the protocol is discontinue metformin for 48 hours, talk to the ordering physician, they will determine if you're safe to go back on it. And then after the procedure, the patient is pretty much free to go back on any medication that they normally take. There's no contraindication that I know of between CT scan and any other medication. Metformin's the one that we, at times, tell patients to stop taking. Okay? But a lot of patients, if they take a lot of medications, will ask you if they need to stop taking them or whatever. You can say you're fine to continue taking them. All right, any questions about any of that? Okay. Thank y'all.